Our first speaker is Dr. Edwina Addo Opare-Lokko. I rehearsed this 1,000,000 times as well so that I get it correctly. Dr. Edwina is a senior specialist family physician and palliative physician at the Greater Accra Regional Hospital, and she also serves as the National Modular Program Training Coordinator of the Faculty of Family Medicine, Ghana College of Physicians and Surgeons, REACH Accra. I'm sure a lot of us know Dr. Edwina and the wonderful work that she's been doing. She has facilitated and participated in many palliative care training workshops, both in Ghana and in other locations as well. And she has helped develop the curricula for palliative care program of the Ghana College of Nurses and Midwives, as well as the GCPS. As a clinical lead of palliative medicine at the Korle Bu Teaching Hospital from 2012, she teaches and mentors students and residents rotating through palliative medicine. She's also a part-time lecturer with the Accra College of Medicine. So you know that this is not her first rodeo. She's very comfortable with teaching and passing knowledge. She believes strongly in the importance of integrating patients' beliefs, spirituality, and culture into their medical care. Her goals are to ensure that every Ghanaian patient receives the best quality patient and family-centered medical care available, and for palliative care to be fully integrated into the Ghanaian health system level. Please, round of applause in the chat for Dr. Edwina. Please, better clap for her before she changes her mind about teaching us today. So please, round of applause in the chat. We'll also introduce the second speaker so that we will just start off immediately. We would like to introduce the second speaker. Our second speaker is Dr. George Nketiah. Forgive me, I tried this one. This one was a bit tougher. Dr. George is a senior family physician in the family medicine / polyclinic department at the Korle Bu Teaching Hospital. And he also serves as the national president to the Society of Family Physicians of Ghana. He's also a faculty board member with the Faculty of Family Medicine. He serves as a consultant for various groups and companies during medical screenings, health talks, medical claims, and many more. From 2015 till date, he has been doing this. He's also a medical officer for the United Nations Interim Force in Lebanon and the United Nations missions in Liberia. Dr. George has contributed generously to research works in Ghana, some of which include uptake of Covishield vaccine and post-vaccination symptoms among healthcare workers at an academic primary care facility in Ghana. So he's done extensive research and has contributed to the knowledge that is out there on key health thematic areas. He also loves to teach and has also been part of giving promotional talks, organizing health programs, and he loves to watch. He loves to read, he loves to watch and play sports. So you can see that we have seasoned professionals who are going to be taking us through this as well. So please, I want to see the round of applause in the chat for Dr. George as well. Yes, please make him feel very warmly welcome. So we will very quickly start with Dr. Edwina, who will take us through the first half of the training. Each speaker has 15 minutes, and so we would also interject to let you know when you have 5 minutes left. You just hear my voice to say, oh, hi, Dr. Edwina, you have 5 minutes left. Over to you, Dr. Edwina. I hope you can hear us.
Yes, please, I can hear you.
Perfect.
And thank you so much, Adora. You did a great job with our names. And thank you to all our partners. Vielen Dank, Mareike. I hope it's not too cold over there. And to Bora and everyone, thank you so much for making this possible. Right. So we're talking about improving NCD control and management. And we thought it's very important to tackle the patient-centered model of care today as an introduction, because it's not that we don't know about the illnesses, but maybe the approach we've been using to manage them may not have been helping us achieve the results that we want. So can we move on, DJ? So over the next 30 minutes, we'll be talking about the introduction, a brief epidemiology of NCDs, the challenges that are associated with their management, the principles of care that we want to adopt, and then George will talk about the patient-centered model of care. So let's roll on. So in my other life, I'm also a facilitator for the NORAD PEN project, which is a project where we are trying to improve NCD management through primary care. I've taken part of my presentation from our overview. So what are non-communicable diseases and why are we worried? Can we move on? Yeah. So basically, non-communicable diseases are diseases that are not spread via person-to-person contact. Some NCDs may be caused by or at an increased risk of acquisition following infections with specific agents such as bacteria or viruses. So an example of this would be the Epstein-Barr virus, which is associated with Burkitt's lymphoma, hepatitis B, and hepatitis C, which are associated with chronic liver disease and hepatocellular cancers. Generally, NCDs are considered chronic diseases. They have a long duration and slow progression. And in many instances, though they are incurable, they may be treatable. So we have different categories of NCDs. Some of them include cardiovascular diseases, and at the top of the list are the CVAs or strokes, chronic heart diseases, coronary heart diseases, hypertension. Then we have diabetes, which may be type 1, type 2, gestational diabetes. Then we have the various types of cancers. Injuries are also considered non-communicable diseases, and we have a road traffic accidents, home injuries, industrial injuries, and the works. Then we have chronic respiratory diseases such as asthma, COPD, hemoglobinopathies like sickle cell disease and beta thalassemia, mental health conditions, we can name them depression, anxiety disorders, schizophrenia. And then we have the various neurodegenerative disorders such as Parkinson's disease, dementia, etc. And these are broad overviews. So let me not forget autoimmune diseases, because those are very important diseases that are causing quite a lot of suffering to many patients. Now, these conditions may occur by themselves, just one condition, or we have multimorbidity and comorbidity. And multimorbidity is when two or more conditions occur concurrently, where one is not necessarily more central than the others. They're all important. So if we come to the clinic, typically you see patients with hypertension, diabetes, and they may have osteoarthritis, and the hypertension and diabetes are both considered to be important, right? Then we have comorbidity, where two or more chronic conditions occur together, but one is more predominant than the other. So you've got hypertension and osteoarthritis. The hypertension may be of more, is maybe causing more problems than the osteoarthritis. But these patterns are associated with poorer quality of life and premature death. And so and they tend to occur in patients who are older. So if you look at the graph to your right, the older you get, the more likely you have multimorbidity or comorbidity, okay? And so these patients end up taking quite a bit of pills sometimes. It's a whole pharmacy going on, and it's not polypharmacy. Shall we move on, please? Thank you. So globally, why are we worried? NCDs cause about 41 million deaths worldwide. That's 71% of all deaths. And almost 75% of these deaths and 82% of the 16 million people who died prematurely from NCDs are from low and middle income countries, which include Ghana. Cardiovascular diseases account for most of these NCD deaths. So if you're looking at numbers, 17.9 million people annually. Then you've got cancers causing 9.3 million deaths, respiratory diseases, 4.1 million deaths, and diabetes causing 1.5 million deaths. That's a lot of deaths from things that could be preventable. And these four groups of diseases account for over 80% of all the premature NCD deaths. To make it simpler, every 2 seconds, somebody aged 30 to 70 years dies prematurely. And I know a lot of us fit within this age group. Now, poorer people are disproportionately affected by NCDs and mental health conditions. So that's not a good thing at all. Okay, so what are the risk factors? There are 5 main NCD risks, which constitute the unhealthy diets. So having a lot of refined processed foods, the things that we like, white bread, white stuff, cakes. I like cake. Then there's tobacco use, air pollution, which is quite rife nowadays, harmful use of alcohol, and physical inactivity. And these are associated with metabolic risk factors such as raised blood pressure, overweight or obesity, raised blood glucose, and raised cholesterol. And I'm sure that several of us in this room or across the network who have one of these things. Shall we move on? Thank you. So here in Ghana, we are worried because generally the risk factors for NCDs are increasing in Ghana. We are growing older, so our life expectancy at birth used to be 58 years in 2012. Now it's 65, 68, and then we are moving forward. And when you hit 60, you are more likely to hit your life expectancy is about 70 to 75 years. So we are growing older, but we've shown that the older you get, the more likely you are going to have chronic illnesses, multimorbidities. Then we are growing richer in some ways, and so we've adopted sedentary lifestyle. It used to be that we walk everywhere. Now with a press of a button, Bolt or Uber will be waiting for you. And our consumption of unhealthy foods and alcohol and tobacco are still worrying. And our risk of premature deaths from NCDs among 30 to 70-year-olds is 21%. That is 1 out of every 5 Ghanaians who are aged 30 to 70%. Now, in Ghana, we have quite a bit of hypertension going on. In the rural areas, the prevalence, age-standard prevalence of hypertension is 22% for men, 28% for women. In the urban areas, it's 34% for men and 51% for women. I don't know what's happening to women. Is it that we are too stressed? But we are at risk. And there's a growing burden of cancer. So definitely we have to do something about it. So, and in the meantime, we still have infectious diseases at our doorsteps. We have malaria still being a problem. We have COVID joining us. Lassa fever is lately another thing that's causing us untold problems, and the hepatitis are there. But the cost of managing NCDs is very high, both to the individual, to the family, and the health system. And if you think about it, you have to take medication for the rest of your life, for most people, which is difficult, and they have to pay for it. The lab tests are expensive, and for cancers and certain other illnesses, the treatments are also very expensive, and they cause increased health service utilization. So it gives us health workers quite a bit of work every day. So how do we address these issues? So we're coming down to the meat of it. We can't do anything without individually without national support. And I'm very grateful for the presence of the Deputy Director General and for the Regional Director of Ghana Health Services in Accra today. And the Ministry of Health launched a new NCD policy and strategy in March 2022, which aligns to the national health sector vision and goals. The basic thing is that we want to attain a healthy population for national development through the reduction of the burden of NCDs. The mission statement says that we want to prevent and control avoidable NCD-related morbidity and mortality through health promotion, strengthening of health resources, partnerships, and empowerment of communities, which we are seeing at work today. And the goal is that we want to ensure that the burden of NCDs is reduced to the barest minimum to be of little or no public health importance. So what else has been done? We've set up a national multi-sectoral NCD steering committee, and this provides leadership in policy development and action plans for NCD prevention and control. It advocates and supports for legislation favoring healthy lifestyle choices. So in Ghana, tobacco tax is enforced, so we don't have as much smoking as other places. And there's a new tax coming in, sugar tax. Then they also do identification and mobilization of resources, and they are strengthening the partnership between NGOs, CSOs, and community to promote healthy lifestyles. Finally, there's an NCD division for the Ghana Health Service, which provides technical leadership in promotion of NCD prevention and control interventions at all levels, including the program and technical guideline developments. Okay. So what are the policy directions for the various, for our service delivery level? We need to do primary prevention of NCD. So can we prevent them from occurring at all? And so we are expected as clinicians to do health promotion, tackle physical inactivity, alcohol use, diet and nutrition, and immunization whenever we see our patients at all ages. And it's a life course approach. Then the secondary and tertiary prevention. So it has happened. What do? We must screen for these illnesses. We are advocating for early detection of these illnesses. Then we must treat them appropriately at the clinical level. And once they have complications from the illness, rehabilitation is important. And at all stages of the illness, palliative care, supportive care is very, very important, because we want to improve the quality of life of the patients and their families. Now, we know that the cardiovascular illnesses, the cardiovascular diseases are usually tackled by previous policies. But in this particular policy, there's NCDs of special concern, apart from the cardiovascular ones, cancers, injuries, sickle cell disease, mental health, oral health, and eye health. So I hope you found your answer to this question from the pretest. So what does living with NCDs mean for patients, families, and for us who provide healthcare? Our patients face challenges. Immediately, we are told that you've got a diagnosis of some non-communicable disease like diabetes, or a cancer, or an autoimmune disease like systemic lupus erythematosus. You undergo shock. You are stunned. You are surprised. And some people feel detached. It's like, is this really happening to me? Then they undergo the grieving process, really. They go through all the stages of grief, because you've lost a state of health. So there's this organized thinking, there's grief, there's helplessness, they feel overwhelmed. They go into denial and avoidance before eventually they accept the diagnosis. So they fight against it, and there's even anger. So all the 5 stages of shock, of grief: denial, anger, bargaining, depression, and acceptance. They go through all that. And for the rest of their lives, until death do us part, they have to deal with illness-related factors such as lifestyle changes. Some of them have to deal with disabilities, which can be very distressing. You lose body parts sometimes because of complications or as part of your treatment, like mastectomy or amputations. Then they have to deal with embarrassing problems, and there's a stigma attached to some of these illnesses. Some of these illnesses are very visible. Your face changes, you have seizures, they can occur at the oddest times. Then there's pain, and they have to commit a lot of time for treatment regimen. For example, if you have a CKD and you're getting dialysis, you're spending significant hours in the week, more than 3 times a week. You're spending at least 12 hours in a hospital, and you have to deal with the cost of treatment. These are serious challenges for anyone in these economic times. Then the family is not spared. They have to carry the burden of physical, emotional, and psychological care, because we can't look after every patient at home. In the hospital. Most of the care is actually taken care at home. Somebody in the family must become a nurse without the training. They must take medical decisions. They must contribute to the costs, the finances. Sometimes they are the ones who feel most embarrassed by what's going on in their family. And there are changes in their lifestyle, their roles and responsibilities. Some of them lose all kinds of money. I mean, catastrophic expenditure, you know, because you take loans hoping that you are going to cure an illness, and then you discover that no, it's not going to happen. In the meantime, now you've incurred huge debts and your children can't go to school. So there's fear of the future for yourself, for the patient, for the children who are left behind. Okay, we can move on. And then there's the physical and social factors, environmental factors. You have to come to the hospital all the time. And hospital environments, much as we are trying our best, they can be very depressing. They are not accommodating. My uncle once refused admission at one of our hospitals because he went into the washroom and put and said that no, he can't sit on a toilet without a toilet seat at his age and with his problems, because he has constipation. He beats a long time on the toilet seats and he can't do that. He had to go to a private hospital. Then the home or hospital environments may not encourage self-sufficiency. And our network members may act as bad examples. So sometimes we health workers go by, do as I say, but not as I do. The patients find you doing the opposite of what you tell them every day. All right. So I was part of a study called the MapCare project, a multi-morbid aging primary palliative care in Africa, where we looked at ways of improving palliative care at the primary care level for older patients with multi-morbidity. And we asked stakeholders, patients, health workers, policymakers, what clinical services should be provided for people living with older patients 50 and above should be getting at the clinical level. So I'll just highlight what we said. All right, so in Ghana, we said that, forgive me, but it's a little small. We harped on the fact that we wanted better communication and assessment, and that patients should be trained, clinicians should be trained in palliative care, that they wanted a multidisciplinary approach to care, even at the primary level, with family support, spiritual care, coordination of care, better waiting time, and we should manage the waiting time and long queues. We should be assessing patient caregivers for bedding, and we should be able to tackle the myths that diseases are punishments, all right? They wanted better involvement in care. They wanted to understand, the patients wanted to understand their diagnosis and the assessments and treatments they needed to get. And they wanted us to learn from traditional healers who deliver person-centered community support. Okay, so we should change the way we look after them. This study was carried out in Ghana, Zimbabwe, and Malawi, and so they also did a similar thing for the other countries. And these are the next slide will show us the similarities for all the countries. So everybody talked about the impact being on quality of life. We want to improve the quality of health and social care services. We wanted to, the stakeholders wanted better utilization of health services and person-centered care services. In the long term, that all the facilities or the healthcare providers would use a person-centered care approach to communication skills, and that there would be holistic care, and that patients would be treated, patients and other health workers would be treated with respect and dignity. All right, so these are the things that they are asking for. So this is the way to go. We want to use simple, cost-effective interventions like the primary healthcare approach, because people with non-communicable diseases or those at risk of developing one require long-term care that is proactive, patient-centered, community-based, and sustainable. And we can do this only through health systems which are based on primary health care. And so we must provide care that is affordable, accessible, comprehensive, and consistent with the patient's beliefs, values, and culture, while ensuring continuity and care coordination as needed. Okay, so what are the principles of care for patients with NCDs or chronic illnesses? Basically, that care of people living with NCDs goes beyond the individual. If you look at this mandala, we're looking at the systems, that we are all part of a system. And you remember from our science lectures, general science, that we are part of an ecosystem. So at the center of the system is the individual, who is made of a body, spirit, and mind. Okay, he comes from a family, and he lives within a family for the most part, and he's affected by his community and the human-made environment. Other things that affect him are his human biology, his personal behavior, psychosocial and economic environment, and the physical environment. Okay, and the medical system influences the human biology, the personal behavior. Work influences your psychosocial economic environment, your physical environment, and your lifestyle affects everything else. But you also come from a culture, a society that has culture and other things affecting them. So when you're going to treat a patient, you need to be able to address all these issues, to be able to manage them effectively, especially when you've got a chronic illness going on. If you only tackle the body, the human biology, without tackling the personal behavior, you are in trouble. If you do not consider the psychosocial economic environment and the physical environment, not to mention their lifestyle, you are not going to get anywhere. And very often, our clinical care has focused on trying to change the human biology, and sometimes we try to change the personal behavior. But because we do not look at the other things that influence the patient's care, then we are unable to, we don't get to the targets that we want to. So these are the things that limit our care as we know it right now. Shall we move on, please? And we also need to understand that these chronic illnesses, these NCDs, cause health-related suffering. Now, what is health-related suffering? It is suffering which is associated with any illness or injury of any kind. It's not about what you think, but it's how it affects the patient and their family. It is serious when it cannot be relieved without professional intervention, and when it compromises their physical, social, spiritual, and/or emotional functioning. So if you begin to think about it, there are any number of ways that NCDs cause serious health-related suffering. That's why they come to us in the hospital or the clinics or wherever we meet them. And that's why they go seek treatment elsewhere. NCDs are major causes of serious health-related suffering. And when you don't manage these things, the components of suffering are spiritual, physical symptoms, cultural beliefs, the psychological or the social experiences. And if you have pain, they can worsen, it worsens the spiritual, it can worsen any of those symptoms, or any of these can worsen pain. If you do not manage these things holistically, then we are going to run into problems. Okay. But how does this help us? Now, when we look after patients holistically, and I'm sorry that you can't see the yellow well, but it has a good effect on cognitive function for those who have neurocognitive problems. It helps to decrease mortality. It helps people live at home more comfortably for longer. It reduces hospital admission and readmission, and it improves physical function. All right, and even good palliative care, much as most people think about palliative care with regards to end-of-life care, even that can help with the quality of life. So that's the whole idea of it. We want to improve quality of life, and being patient-centered is the best way to go about it. So now I'll hand over to George, and he'll talk about the details of the patient-centered care model. Thank you very much.
Thank you very much, Edwina, for this intro and expanding this presentation and the issues. And I think it ended up with the benefits of holistic care. I mean, it's already told us the burden of the disease, the challenges that clients are having, not only clients, but their family as well. And now saying that there are a lot of benefits if we give a holistic care. And what's the model of care that will help us to achieve this? Next slide, please. So there are actually a number of models, but we're looking at 3 models to actually bring out what we want to, to let our audience know. A model of care actually provide framework for understanding the processes of care. So it helps you to know how to go about it. It guides your actions by defining what is important. So you have a client, you want to get the information and help this client achieve control for probably a condition. How do you go about this? What's the model that will guide you? Effective models actually simplify the complex situations and focus attention on what is important for understanding and action. So if you're having a model that is not going to help you unravel these complex issues, then it will not be the best. Next slide. So we'll be looking at the various ones. And the one that I'm sure a number of us know and a number of us have been practicing is the conventional medical model. A lot of people will refer to as the doctor-centered model, where everything is concentrated on the doctor. The doctor is the organ, the doctor is the one who is making the decisions, nobody talks. And it happens in our consulting room. When the doctor speaks, patient doesn't speak back. A lot of times patients are sitting in front of us and shaking because everything is doctor-centered. Sometimes it is disease-centered. This client is sitting in front of you, has had malaria probably for the past, every man having malaria, but comes there and all that we are concentrating on is that small plasmodium that is causing this condition, getting something to kick it. But what is actually leading to this number of presentations? The conventional model normally assumes disease to be fully accounted for by deviations from the norm of measurable biological somatic variables. So you're looking for this parasite, looking for this, this deviation in probably the production of insulin by the pancreas or insulin resistance. But there are a lot of other things that may be affecting, this condition. And this one actually leaves no room for in the framework for social, psychological, and behavioral dimensions of health. And as we go on, you come to realize that there are a lot of other things that actually affect one's illness, one's condition, and we need to actually assess that one as well. Next slide. In 1980, there was some improvement in the way people take look at things. A lot of people realized that this conventional model is not helping, and they actually brought up what we call the biopsychosocial, trying to incorporate the aspect of the social and the psychological aspect of it. So it's very valuable in reminding us to consider the person and the social dimensions of the illness, in addition to the biological aberration. So you have a client that is in front of you. Let's say somebody who had an industrial accident. Somebody is thinking about it. Is it because of the environment that it happened? Or is it psychological? Was this guy stressed and thinking about this economy, what is going to, he's going to pay school fees in the next week and thinking about where he's going to have money to pay school fees and loses concentration, or probably even having hypoglycemia and just loses concentration and get this accident. This actually, this model actually looks at all these aspects and try to bring it together to find out what the cause is. And it's actually based on what we call the systems theory. In the systems theory, we are looking at the patient who is conceptualized as being composed of systems. So you are made up of organs, tissue, cells, molecules. That interacts and interdepends on, interdepends on each other, and also related to some suprasystems like the families, living within a family, Edwina said, among the community and even a nation. Of course, when the economic crisis comes, it affects everybody. So when you're looking at what is causing the issue in front of you, just don't concentrate on the biological aspect of it, not just on the disease, but looking at all the other things that come together that interrelates and depends on each other to cause this. And this was the biopsychosocial model. Next slide, please. As much as it was a good improvement, it still had some limitations. The model did not actually explain when and how to include these other dimensions that we've talked about. 2, it didn't interact and involve patients in the care. So you have a client with you, you are looking at, yes, probably he's stressed, probably the environment is not good, but do we interact and involve the patient in the care? That was one of the limitations. And there was no, it wasn't explicit about when and how to go beyond the conventional model of care. So the next one that came, which we want to propose to you, and which everybody is embracing over the past few years, is a patient-centered care, the Addo model. This integrates the conventional understanding of the disease trying to get the disease. A lot of doctors and a lot of clinicians have been trained to know how to diagnose a condition. Yes, understand what is going on. This client, is known to have diabetes. You've checked your blood sugars. Your fasting blood sugar is more than 7. Probably done your HbA1c more than 6.5, and you're happy you've diagnosed it. But this goes beyond that. It involves the patient's unique experience of illness, which we'll talk about, and also interacts and involve the patient in care. Care, involves the patient as well, not only the clinician who is at the center, but involves the patient in management, in setting goals, and all that. Next slide. So the patient-centered clinical method, it's also a process of consultation that involves 4 interactive components. They are interactive. So first one, you are exploring patient health, you are exploring the disease, you are exploring the illness experience. Second, you want to understand the patient as a whole. 3, you want to find a common grounds regarding management. And 4, you want to enhance patient-doctor relationship. And we'll take them one by one as we expand on it so that we can understand it and we can apply it in our care. Next slide. So this is a pictorial aspect of what I actually said, exploring the patient health, disease, and illness, which interrelates and with understanding the patient as a whole, the link together with finding the common grounds and enhancing the patient's physical relationship. Next slide. So let's look at exploring the disease. This a lot of clinicians are trained in doing. Yes, a lot of clinicians are well trained in discovering and characterizing disease that the patient brings. So, you go through your history, you do all that. At the end, you say, oh, this client has hypertension because the BPs are high, beyond 140/90. You finish, this client has diabetes because the blood sugars are high. Disease is actually the theoretical construct by which physicians explain patient's problem in terms of abnormalities of structure and or function of body organs and systems, both physical and mental. So client comes to you, you have your PHQ-9, you go through it, you think that this patient has depression. We all know how to do it. It is exploring the disease. And a lot of things that we do, try to explore the disease. So presenting complaint, you've gone through your history of presenting complaint, you've gone through your ODQ and systemic review, trying to rule in or rule out what might be going on. At the end, you go through the drug history and all that, you do examination, you do your investigations, bam, you have the diagnosis. Yes, we are well trained in this, and we indulge that if you are not well trained or you are not conversant with it, we try to get the guidelines and all the things that we need, trying to get what is the disease, what is causing this. Disease explored by processes leading to differential diagnosis, I said, using your history, physical examination, and investigations. Next slide. But it doesn't end there. A lot of us with our care process ends with exploring the disease, but a lot more to it, especially when it comes to chronic diseases. 1, exploring the illness experience. What does it mean? Illness is actually the patient's personal experience of ill health. You think this client has diabetes, but what does the client think of, that is going on? There are a lot of people who come to our hospital, they have diabetes. You tell them they have diabetes, all they say is that they think that there is somebody from the village that is causing it. You have somebody who has, a cancer probably of the breast. You tell the person, this is what we are finding now. This can't happen. It's coming from my village. Probably because I got a new employment, I got a new car, people from my village are chasing me. Of course, for us, a lot of time we say that we are going to manage this condition. These about people or other people are saying that, look, I'm going to cure this disease. If you don't explore, you are not going to know. So a lot of times you need to explore what the client thinks is going on. And we can have a simple way of going about it, which we call the FIFE. The first one, F, is the feeling, Y, or the fears. What does the client think about what is going on? What are the fears? Probably something is going on. The client thinks that for diabetes, if you get it within the next 5 years, you are gone. So the client is coming in, he's been told that you have diabetes and is scared. If you don't explore this patient's fears and feelings about what is going on and address it, client is going to go depressed, a whole lot of things going on that you may not be able to address. Second one is the ideas about what is going on. A lot of times you just will need to ask the client, what do you think is going on? There are times that you yourself, you are lost, but the client might know what is going on. Somebody will tell you, doc, yesterday what I ate, I'm sure this is what is causing it. Or tell them I went probably to a party, they gave me a drink, and after that, I've been experiencing, I'm having this feeling. Or they will tell you something that, they think is causing it. A lot of them might be wrong. And that's where the issue also comes in. When it is right and you don't know, it guides you. But a number of times, people have different ideas as to what is going on. As I said, somebody may have a cancer probably of the cervix. You diagnose it and tells you that this is not a hospital thing, or this is coming from my village. Let me go to my village, go and do all these things. If it's not going, then I come. They come, and by the time they get back to us, it's too late. What are the ideas? If you know the ideas, you can help address it. The impact of, the problem on the function of the patient. So there are times that there are things that are going on that is not, allowing this guy to even sleep. At work, they can't concentrate. There's back pain that is going on. I can't go to work. If it's affecting function, then you need to know, you need to address it. Well, probably that is a major problem for this client, but they come and it's never addressed. The last one, the expectation. What is the client's expectation of, the consult? For you, your main what you want to do is to bring the sugar down, but this client has a different expectation. Sometimes we need to, you have hypertension. Client comes in, you're not, getting what is, he was expecting from the consultation. You give medication, tell this client to come in a month's time. For the client, I've come to the hospital, they are going to give me medication. This hypertension is going to vanish within 1 month, and hooray, I'm not coming back. But if the expectation is cure and you're able to address it and tell them that for this condition, we are going to manage it, it's not going to be cured, then this client knows that, look, I have to be coming every month to be taken care of. And that's why we are losing a lot of clients to follow up. They don't know the expectation is cure. We don't tell them that this is going to be. So a lot of times as the clients come in, we need to explore their illness experience, get to know what is going on in their head, what they are thinking about, so that we can address this, especially when it comes to chronic conditions and non-communicable diseases. Next slide. I think there's one slide that did not come, that exploring the health. When we talk about exploring the health, what does the client think of about health prevention, about health promotion? When you look at the strategies of the Ghana Health Service and Ministry of Health, it was clear that the main thing with non-communicable disease and chronic diseases is prevention, and promotion. This client comes to you, you have clients coming to you at the clinic. Have you ever asked them, are you exercising? Are you eating healthy diet? Are you abusing alcohol? A lot of time we've been trained, but when the last time that you saw a client that you went to social history and actually asked, are you taking alcohol? How much of alcohol are you taking? Is the client really abusing alcohol? It becomes a risk, and of course, if it is not dealt with, gradually this client may develop one of these NCDs. Is the client smoking? Not the last time this client actually did some health screening. If the client have some chronic conditions, you're going to the tertiary one, is the client actually being taken off? Is he taking the medication? So a lot of times, you must explore the patient's health as to how they actually recognize and take their health serious and the things that will promote their health. And that is exploring the patient's health. It's very important when it comes to non-communicable diseases, especially when these are becoming the major concerns. We need to explore so that we can help them so that they don't actually develop other comorbidities. When Edwina was talking about comorbidities and all that, there might be hypertension. If we don't take care of himself well, they get complications. They may get other conditions, dyslipidemia, they may get diabetes. So we need to explore and help them so that we prevent some of these things from going on. The next one is actually understanding the patient as a whole. Understanding the patient as a whole. Look, a person does not exist in isolation. And I always make this point. The experience of health, illness, and disease are profoundly impacted by their personal development, their proximal context, and their distal context. What do we mean by this? No two clients are the same. I always repeat it that no two clients are the same. One client might be coming from East Legon. For those of you who do not know East Legon, that's the posh town, place in town. That's where you see all the, big cars and all the big houses And these are people that probably may be earning 10,000, 15,000, 20,000 a month, or even in dollars. You can also have another client that is coming from another community. Probably I don't want to mention, but probably this client is making just about, 500. The environment alone, there's even not a place, of convenience for them. There's no place for exercise. This other place there, there are courts there. You can go and play your tennis. You can jog at ease. The other place, there's not even a place to sit, more or less. A place to go and jog. You open your house and you're on the street. You can't jog on the street. So you need to know where they stay. You need to know other things that affect them. You need to know the patient as a whole. Personal development, the patient's childhood upbringing, the patient's relationships. Probably the relationship that this person have had has created a lot of things, and psychologically this client might not even be stable. What are the successes of this client? What are even their beliefs? These are all personal development that affects care. Most of our old folks, will tell you that, look, when you are not born, we're using, herbs and these things. What is this? Medication you are talking about that I have to take every day. That's their belief. If you don't realize that this affects the patient and you don't actually explore and take note of all these things, you give this client medication, throws it away, go and take other things. By the time they are in, they're having kidney issues, other problems. They'll come and admit that, yes, they did not do the right thing, but it's too late. But when you address some of these things early, it's going to help them, especially when it comes to non-communicable diseases. Next slide. The personal context, the patient is living among a family, and the family environment affects health. The family environment affects health. You told this guy that, look, you need to take low salt. But who's going to cook? Is the wife. If you don't involve the family, you go, you tell you, okay, but go every food, a lot of salt because the wife likes salt. Finances, you're going to write medications. You not ask how much this client earns. You're going to write a medication that costs probably 1,000. A lot of times they are shy of us. Oh, doc, I'll get it. But this client goes, throws this thing somewhere. I don't even know what I'm going to eat in the evening. You give me a prescription of what, 1,000? You're not serious. A lot of time we need to assess all these things as we take care of our client. The educational level is also extremely important. How they will even understand. Somebody who is a tertiary, who has gone to the tertiary level in terms of education, and somebody who has not even gone to class 1, the understanding of what is going on. So we need to look at all these things. Employment. Somebody is a banker, goes to work at 7 o'clock, comes home at 8, and you're saying he should go to the gym. When is he going to have time? There may be other ways that you could explore in terms of their side, their religion. We all know that religion also may play, some important roles. And we need to know all these things so that it helps us to take care of the client's role. The distal context, which also a lot of times very much ignored. This child is in the secondary school. This child is in the tertiary institution, comes to you. You are not exploring their community or where they are. Probably in school, a lot of things going on. They are smoking, they are using some illicit drugs. If you don't get to know where their community, so there are communities that may be very well known for, use of drugs, community that may be well known for certain things. And there are times that you need to explore all these things if you want to understand the client as a whole. Even the healthcare system, somebody who has, let's say, autoimmune disease, who stays, far away, let's say in the Volta region where there's no rheumatologist. If you don't actually ask, probably the client has moved all the way from Volta region to Accra to access care. If you don't explore where they live, where they are even healthcare system, there are people there who can help with the care. Then you start something that you never complete and the client doesn't benefit. So a lot of time when you are seeing client, we need to understand them as a whole because everything that is around them impacts on their health. And that's why we talked about the systems theory. A client has organs, tissues, cells, molecules, they interrelate and interdepend on themselves. Not only that, but there are supra systems, the schools, the families they are in, the communities they are in, affect their health as well. And when we are actually seeing our clients, especially with non-communicable diseases and chronic diseases, we need to explore all these things to understand the client better so that we can help them better as well. Next slide. The next one is finding common grounds. In developing an effective, the word is effective, management plan, you need to find common grounds. Gone are the days where every decision depends on the doctor. The doctor is the one who, is taking the decisions. When he speaks, nobody speaks. Gone are the days. You won't achieve anything if you're going to go along that line. Unfortunately, doctors have become thin gods. People come to the hospital, they sit in front of you and they can't speak, because when they speak, the first thing that comes down, what do you know? Did you go to medical school with me? But those days are gone. Research have shown that if you are going to go that way, your outcomes are not going to be good. You need to develop an effective management plan by involving the client. One, in 3 areas: the nature of the problem, the goals of treatment, and the roles of the doctor and the patient in the management. Next slide. The nature of the problem and priorities. Patient education on the condition and checking the understanding is extremely important. A client comes to you, you are saying that this client has diabetes, you've not explained what it means, what are the complications, what it is. The client says it's just like malaria, medication for a month, it's done. You don't explain as to the control that we are looking at for. You have in your head that, look, I want to have a fasting blood sugar of less than 6. Clients came with 18, gets 9, very happy. This doctor is a very good doctor. My sugar was 18, it's gotten to 9. In the next 3-5 years, complications, because if the client doesn't understand what is going on, the problems, then you are wasting your time. Trust me. I've had a number of clients just educating them and letting them know what it is, the targets and all that. They know what the problem is, they know what the goals is, they know what the targets are. These clients are able to take care of themselves. When they realize that sugars are going up, they know that, look, there's something going on. When they realize BPs are going up, they know there's a problem. Somebody who probably has asthma knows what to do, because he knows that I need to rise to the hospital now, because they understand. If you don't involve the client and you think that everything is with you and it depends on you, you are making a big mistake. The client must understand what is going on. And there's a place for educating your clients very well, especially when it comes to this, because they are going to be with this condition for a very long time. They need to understand it and probably even understand the condition that they have more than you. The next one is dealing with misconception in quieting fear. So somebody has diabetes knows that when people get diabetes, 5 years, they are gone. I have clients who are 85, who are 90, and they are still well controlled and doing very well. You need to let the clients know. You need to quiet their fears. You need to build their hope. When they have the misconceptions as to what is going on, they've heard a lot of things. This medication that they are going to take, when you go to bed, your wife will sack you. You need to address some of these things. You need to deal with conception, with what the problem is and the treatment. Remember that there needs to be information sharing, and it should be open and two-way. Try to get a lot of information from the client concerning it, what they think about the condition, the problem, where there are misconceptions, try to address it. And you also need to give a lot of information to this client to know what it is, what condition they have, what are the issues with it, what are the complications that may arise if they don't take care of themselves well. Next slide. The next one is agreeing on common goals. We talk about common goals. All the goals of treatment is in your head. I want this client to get to blood sugar of less than 6. HbA1c after 3 months, I want to go below 7. 2-hour postprandial, I want to go below 8. I want the BPs to be below 140/90. It's in your head. The client doesn't know. It's not going to help. Goals must be realistic, well understood, and achievable. That's the first point. You don't set goals that, it's not achievable. This client has not even exercised before. He's telling you that he goes to work from 5, comes at 8. The first time at the clinic, you are shouting at the client, you need to exercise, you need to do this, exercise 150 minutes of moderate intensive exercise 5 times a week. The client just look at you, well, how am I going to exercise? It must be realistic. Probably you can start, okay, you can use arms to do 15 minutes morning, 15 minutes in the evening. If you can do even once or twice a week, we can start from there. You build up. The goals must be realistic. Some of them, clients, I mean, this guy has been eating fufu 3 balls. You are telling this client that he should go half ball. All of a sudden, I mean, it's not going to happen. This guy is taking 3 balls of banku, and you're telling that, I mean, you need 7. So all of a sudden, cut off your food. The first time he does that, he may be going to hypoglycemia. He may not even come to your clinic again because he sleeps and, I mean, we call it Nketiah. I mean, as if you can't move your hands. And the next day, this client is not going to come to you again. You need to have realistic goals. And it must be well understood by both parties and achievable. Goals must be agreed by both parties. We are agreeing that, look, we want to get these sugars below fasting of 6. Probably want to start fasting of 7. We're going to go to 6. Both agree. The client would help, the client will cooperate so that you achieve that goal because it was set together. There are times that we just set the goals. I mean, we don't involve them. It is our goals. They come, sugars are still, we shout at them, you are not getting to go. But the client doesn't know. Client knows that BPs are supposed to be 140, 90. When he checks and knows that it's 150, he knows that, look, there's something wrong. It's either I'm not taking my medications, which probably they'll rush and go and take it, or because there are other things that might be causing this, and they will come to you. Goals must be monitored by both parties. When the client is monitoring, you are monitoring, the outcomes are better. He knows that something is wrong. He knows that he needs to get there, and will put in much to get there. Next slide. Agreeing on roles. Who has the disease? The client. A lot of time we play the role of God. And is the client that has the disease? Is the client who's going to take the medication? Is the client who's going to exercise? Is the client that's going to go off the fufu? Is the client who's going to go off the banku? Not you. Don't just go and just mention it. Have roles. I'm going to see you every month. That is my role. I'm going to make sure that I'm going to check you so that I don't get complications. That's my goal. I'm going to check any complication that might be coming through or thing that I need. That is my role. Your role is to take medication. Your role is to try and exercise. Your role is to do this. Have roles. Your role is to make sure that you are coming to the clinic every month or every 2 months. There must be roles, and the roles must be agreed. Whenever there are shared roles and everybody agrees on their roles, there are better outcomes. Remember that sometimes it should be negotiated rather than imposed. Doctors like imposing. We like imposing, clinicians. But look, it is the client. So there are times that we need to negotiate the roles so that everybody agrees on what he or she is doing. And the last one, we should be accountable. Clients should be accountable. Clinicians should be accountable with their roles. I'm supposed to see you next month. I come, you are not in. I come next 2 months, you are not in. The next time I'm not going to come. You have roles, I have roles. When we agree on the roles, let's play our part and let's be accountable. Next slide. Linkages. This is a very special one, that I've chipped in, and it comes to the role of the clinician or the doctor. It's an important role of the doctor. A lot of people come to the clinic that need a lot of support, that we need to link to support. And that is our role. We realize that you need to involve family. You need to. You probably will do a family circle, get to know the very important person in this person's life, get them involved. There are times that you need to do a family conference. You realize that this guy needs help. How are you linking this client to the help? There are times that you need to call the family in and say that, look, this guy has hypertension. He needs some help. Somebody needs to monitor the medications. He's struggling. Somebody needs to help with the food at home so that he doesn't eat just anyhow. Somebody has to just remind this guy to take his medication, help him. You need to get linkages to support for the client. A lot of time we just leave them, to the pool, and they get there and get lost. Community support as well. What are the community-based resources that are available to your client? This client wants to exercise. Do they have a gym in the area? This client needs to go for physiotherapy. Can you link this client to a place where the person can go? They need support. Look, these clients have a lot of challenges, as Edwina said, personal challenges, family challenges, and a lot of times they may need a lot of support. can be emotional, it can be all sorts of support. And it is our role as clinicians to link them to some of this support just to support their care and to help with better outcomes. Next slide. The last bit of the 4 stages is actually enhancing the patient-doctor relationship. And that's why we talked about continuity of care. First, remember that chronic diseases, client is going to have this for a long time, probably the rest of their life. And when you build that relationship, they open up to you, they share a lot of things with you so that you can guide them. If you don't build that relationship, client sitting there, doctor sitting there, no information comes up. I mean, but the client can just ask 3-4 questions, you write medication, client is gone. Client is never controlled. I mean, things are not going well. I mean, it's an indictment on you as a clinician because you need to be able to do that. But if you don't go through some of these things and open up, it's not going to help. Remember that relationship can be a healing or a harmful, aspect in terms of impact to the client's health. Let's build good impact, good relationship that will build healing impact on our clients. 2, there should be a conscious effort by the physician to build an effective long-term relationship with patient in the context of continuity of care. There are a lot of research that have been done with continuity of care, and it said that for a lot of these non-communicable diseases, if there's continuity of care, the outcomes are better. If you build relationships so that this client is seeing you for a long period, most of the time, or a team will be able to see you. The outcomes are better, and it comes with the relationship. So let's build good relationship with our clients, especially when it comes to this, non-communicable diseases. The last last 2 involve sharing power with their patients as a basis of working together and benefiting from its healing process. I've already said that it is not you who has the disease. You need to have good working relation with your client, common ground, and let's share the power. Don't keep the power only to yourself, guiding, directing, and imposing. Let's share. But remember also as a clinician that being too close can be dangerous in a variety of ways, to yourself as well. So a lot of times, as much as I want to build the relationship, let's remember that we need to be careful in getting